I'm Yvonne Morel. I'm going to be moderating the next session, which is the complex transposition decision-making across the lifespan. And our first presenter is Dr. Jacqueline Weinberg, who is the director of our perinatal program here at Children's Hospital, and she is assistant professor of pediatrics. She's going to be talking about the fetal diagnosis and approach to counseling in complex transposition, and where do we start with that?
Good morning, everybody. Thanks to Dr. Morel and to Dr. Olivieri and Dr. Morel for organizing the symposium today and for inviting me to speak on fetal diagnosis and counseling in complex transposition. When we think about diagnosis, prenatal detection of transposition in general, we know that there's been overall a low rate of detection of TGA of only about 50%. In this near modern era, the studies shown on the screen, these low detection rates owe predominantly to the fact that this is not a lesion that's easily visualized on just a basic 4-chamber obstetric screening ultrasound. In 2012, the AIUM guidelines were updated to include the outflow tracks on even routine low-risk screening obstetric ultrasound at mid-gestation. And so more recent studies that have been in more localized populations have shown a higher rate of detection. We do know that associated findings, when they are present in transposition, this may lead to a higher rate of prenatal detection. As we've heard from other presenters already today, associated findings can include the presence of a VSD, anterior or posterior malalignment of the conal septum, and thus right or left ventricular outflow tract obstruction, aortic arch anomalies, and abnormal AV connections. Additionally, on fetal echo, we look at a lot of the physiologic abnormalities. Importantly, in transposition, this can include restriction at the atrial septum or the ductus arteriosus, or even reversed flow in the ductus arteriosus. These findings can help us to prognosticate about what the postnatal course is going to be like for these infants. So I'm going to talk through a few cases today showing some fetal pictures and what our counseling was with the families in these cases. In our first case, this woman was referred at 20 weeks gestation due to concerns for congenital heart disease on her obstetric ultrasound. In the top image, we can see that the anterior ventricle, which was a morphologic right ventricle, gives rise to the aortic valve and aortic arch, which is more superior, and the posterior left ventricle, leftward and posterior ventricle, gave rise to the pulmonary artery here. You can see that there is a little bit of crowding in that area of the left ventricular outflow tract. In the image on the bottom, we see, again, that parallel relationship of the great vessels. There is a blue flow here that represents a ventricular septal defect, as well as accelerated flow across that left ventricular outflow tract. In the view on the right, even at 20 weeks gestation, there was concern for some reversed or bidirectional flow in the ductal arch. At a follow-up at 31 weeks gestation, we can see from this sweep from a 4-chamber view up to the outflows that the more posterior and leftward left ventricle gives rise to this artery that bifurcates. That's the pulmonary artery, with a narrow passageway between that left ventricle and the pulmonary arteries. The anterior right ventricle gives rise to the aortic valve and the aortic arch. In the view in the center, we again see that relationship and can see that there's pretty tight connection between the left ventricle and those branch pulmonary arteries. On the top right, we see a short axis view where we can see the relationship between this left ventricle here and the smaller pulmonary valve here, with that narrow connection between the LV and the pulmonary artery. And we can see that the larger caliber aortic valve here arises from the anterior right ventricle. In the bottom two clips there, we see, again, the aortic arch with a reverse-oriented or vertical orientation of the ductal arch with either bidirectional or left to right reversed flow in that ductal arch. She had one last follow-up at 35 weeks gestation. Again, from this view on the left, we see that parallel orientation of the great vessels with the anterior aorta coming off of the right ventricle and the posterior pulmonary artery bifurcating here with a narrowed connection between the left ventricle and the pulmonary artery. Interestingly, the VSD is more difficult to view at the level of the semilunar valves, concerning for it being more remote. In the view on the right, we again see that flow from the left ventricle to the pulmonary artery here, there's some acceleration of flow right there. This patient was counseled about the ductal dependent nature of this lesion and that prostaglandin would be started after delivery. There was a possibility of a need for a balloon septostomy after birth, but that if there was still limited pulmonary blood flow, concerning because of that reverse flow in the ductus, that a BTT shunt or a PDA stent may be necessary after birth, and that given the size discrepancy between the aorta and pulmonary artery, that there was concern that a simple arterial switch operation would not be possible in this case, and that a Rastelli or Nakaido or other procedure may be needed, but that the timing of that intervention would vary. This baby is actually, I believe, the third case that Adam showed you, and the baby was initially stable on prostaglandin, but then due to episodic cyanosis, underwent a balloon septostomy on day of life 3 or so, and then at about 3 weeks of age, underwent a PDA stent, and because of the coronary concerns that he had mentioned, underwent a Glenn procedure before an eventual Rastelli procedure and Glenn takedown at a later age. In the second case shown here, this woman was initially referred at 26 weeks gestation due to suspected congenital heart disease on an obstetric ultrasound. Her follow-up images that I'll show here were at about 30 weeks gestation. In that view, very similar to the last patient, on the left here we see parallel great vessels with a more anterior aorta, which is superior to the pulmonary arteries seen here, which arise from the more posterior leftward left ventricle, with a fairly narrow left ventricular outflow tract. In the middle image, we can see that there's a very large ventricular septal defect, which is down closer to the AV valves, concerning for having at least an inlet portion to this VSD, and that the pulmonary valve seen here does appear to somewhat override that ventricular septal defect, but that there's crowding at the valve or in the subvalvular region. In the image on the right, we again see there's flow seen here across the VSD, and there's acceleration of flow between the left ventricle and across that pulmonary valve. And here we can also see this flash of red back here represents the ductal arch, which appears small in caliber and has bidirectional flow. This patient was also counseled that the baby would be started on prostaglandin after birth, that there was a possibility of needing a balloon septostomy. There was some hope because the pulmonary valve annulus measured normally on these studies that an arterial switch operation with some resection of the subpulmonary tissue may be possible. However, they were counseled that if that subpulmonary or pulmonary stenosis was more significant, that the repair may be more complex and that could include an initial palliative step prior to a definitive repair. This baby, interestingly, was very profoundly cyanotic postnatally, despite prostaglandin and a great deal of interventions by our ICU team, but required a balloon septostomy pretty urgently at about 8 hours of age. And happily, the condition improved significantly after that, and the baby was eventually able to be discharged to home and returned for a Nakaido procedure at about 6 months of age. My next case This woman was referred at 21 weeks gestation due to an abnormal ultrasound concerning for a conotruncal defect. In the image at the top, we can see that there is a ventricular septal defect. There's flow here between the ventricles, and it does appear to be predominantly in the inlet portion of the septum. Again, also at 21 weeks on the left, there was concern for, or you can see that the aorta arises from the anterior right ventricle. You can see the aortic arch there, and that there was reverse flow in the ductal arch, and no obvious antegrade pulmonary flow was able to be seen on this study concerning for pulmonary atresia. Follow-up study at 34 weeks gestation, we can see up here in this sort of four-chamber and sweep up to the outflows. This is the left ventricle here, the right ventricle. There's a large VSD in the inlet portion of the septum with a fairly long course between that left ventricle and the anterior aortic valve here. The pulmonary, atretic pulmonary valve we can see is associated close to that left ventricle right there, consistent with a TGA anatomy with pulmonary atresia. And also at 34 weeks on the bottom here, we again did not see antegrade pulmonary flow, but could see flow from a reverse ductus arteriosus to confluent branch pulmonary arteries, which were felt to be small. This patient was counseled that this is obligatorily a ductal-dependent lesion for pulmonary blood flow, and that the baby would require likely an initial BTT shunt or PDA stent, followed by a Rastelli procedure later, which was in fact what happened. The baby had their BTT shunt at 4 days of age, followed by the Rastelli at about 4 months of age. And the last case that I have for you guys, this patient was referred at 21 weeks gestation due to concerns for congenital heart disease, again on the OB ultrasound. In this case, this is sort of the opposite end of our complex spectrum. Although the arteries, great arteries, do arise somewhat in more parallel than normal, the anterior aorta in this case is smaller in caliber compared to the larger pulmonary artery that arises from the left ventricle. You can see there, with that pulmonary artery overriding the ventricular septum. We can see both from that 2D view and this color compare here that the aortic arch was small in caliber, and you can see that that flow, as we say, hangs up in the aorta. There's some continuous flow with an abnormal pattern in the aortic arch. This represented a Taussig-Bing anomaly with transposition or malposition of the great arteries with an overriding pulmonary valve and coarctation and hypoplasia of that aortic arch. A follow-up study at 29 weeks gestation in the same patient, we again can see that nice parallel arrangement of the great vessels. The larger pulmonary valve overrides the VSD. The anterior aorta with nearly side-by-side, but anterior aorta is smaller in caliber. And we can see that there is a VSD present with extension to the inlet septum as well, with that pulmonary valve possibly overriding more of the right ventricle, consistent with a double outlet lesion. And in the short axis, though, we see that that left ventricle potential baffle over to the aorta would be right in this area, or sorry, to the pulmonary valve, which would be the neo-aorta. That patient was also counseled that this would be a ductal-dependent lesion with a possible need for a balloon septostomy after birth, and that surgery in this case would include arterial switch operation with a baffle closure of that VSD and an aortic arch repair. The postnatal course, this baby did not require an initial BAS, but underwent a complete repair on day of life 5. To sort of summarize what we counsel with our prenatal patients. We include several components of our counseling with these families, but that does include delivery planning, including the location of delivery at a tertiary care center. As I discussed, some of these patients did require pretty urgent interventions after birth, and as I like to say, you can never trust a transposition. We discuss the need for those urgent interventions and always the use of prostaglandin. We get into what we expect the interventions will be for the baby with palliative procedures versus a definitive repair as the first stage. And we try to discuss the potential options for what that definitive surgical repair will be. But the differences, a lot of the differences, as you've heard from my colleagues, in which type of definitive repair are really not things that we can definitively say in fetal life, although we try and cover all our bases and discuss the possibilities with families. We also discuss the long-term outcomes for these patients, the potential for residual disease or additional need for cardiac procedures later in life, such as for pulmonary valve replacements or residual outflow tract obstruction or branch PA disease. And importantly, we discuss the neurodevelopmental outcomes and things like learning and behavior. As we know, a lot of research has been done with transposition in particular, and the neurodevelopmental outcomes being significantly different than the general population. And one of the biggest risk factors has been shown to be more complex anatomy and complex repairs, including VSD closures and arch closures, as well as outflow tract obstruction. And so this is all part of our counseling with these families to try and prepare them for the next steps, which is what some of my colleagues will now get to. Thank you, everybody.